research is on maternal mortality and mental health. Next slide, please, Haley. We'd like to first set the scene of maternal care in Virginia. The March of Dimes has created a term, a maternal care desert. What a maternal care desert is it's a geographical area that lacks appropriate prenatal labor and delivery and postpartum care. Without the proper care, there's a higher risk of developing complications that could lead to mortality. This disproportionately affects low-income and minority populations. So the deeper the color on the map, it's more considered a maternal care desert. This, out of the 95 counties, this affects 35 counties in the state of Virginia. Next slide, please. So I thought it'd be best to start out with, screening for depression as far as mental health care goes for maternal mortality. This data comes from the Department of Medical Assistance Services. It said that there was a checkbox for yes or no. It didn't clarify if it was the patient or if it was a clinician that was doing the checkboxing. But as you can see, the blue columns are the false, which means they were not screened, and the orange columns were true that they were screened. So you can see it's disproportionately during pregnancy and after pregnancy of women not being screened. Northern Virginia did a great job with 92% of their patients screened, and Central Virginia and Southwest Virginia combined to make 7% of their patients screened for depression. And Haley will take over from here.
Thank you. So according to the CDC, mental health conditions were the leading underlying cause of maternal deaths between 2017 and 2019. So looking at the data on the left, you can see that mental illness was in the top 10 critical factors for maternal mortality. And looking at the graph on the right, at the toxicology report, mental illness medication was the most common medication found at the time of death. Mental illness medications were followed by recreational drugs, which is also something to consider, is substance abuse, which can have associations with mental illness. According to the NHI, 43% of people being treated for painkillers, substance use have a diagnosis or symptoms of mental illness. And then among pregnancy-related deaths, more than half occurred between a week to 1 year after pregnancy. As you can see from the graph on the left, mothers with mental illness that were treated before, during, and after pregnancy have full lines at the top of the graph. However, as you look down, the care during and after pregnancy seems to fall off the wagon. More than half of the mothers did not receive treatment after pregnancy. And from the data, we have found that 87% of deaths of mothers with mental illness were preventable. In the graph to the right, the prenatal care index shows that 27% of prenatal care is less than adequate, but the CDC recommends increased screening for postpartum depression and anxiety. So from our analysis, we are looking to increase follow-up and prevent lack of treatment. And then this is just a quick comparison of the maternal deserts that Eric showed versus severe depression rates. And just comparing the graphs, you can see some similar regions that have high severity in mental illness, but also do not have access to maternal care.
So with that access to maternal care, we can take into account how women are funding their perinatal care. Socioeconomic status is related to mental illness. People who have a low socioeconomic status are 2 to 3 more times likely to suffer from mental illness. 30% of women who have completed up through a high school education are also diagnosed with mental illness, which is a higher percent than women who have completed college or further education. So looking at this graph here, if we look through perinatal payment methods, women who were on government Medicare, Medicaid methods, there were a higher number of women across the state of Virginia who used that to pay for their perinatal care compared to women who were using insurance or women who were self-pay. Next slide, please. And then from there, we can look at how women who were suffering from mental illness were broken down by their method of payment. So women who were using government assistance there were higher numbers of women who were using government assistance who were also diagnosed with mental health disorders. We have drug use disorder, depressive disorder, which is different from depression, also tobacco use, which is classified under an addiction umbrella, and then anxiety disorder. So as we move forward in developing a solution, looking at the number of patients that are on government care, completely outranking the other women who are using other methods of payment for their perinatal care, we need to ensure that government assistance programs have that mental health screening capability for pregnant women and women in that time zone after giving birth.
Hello guys, since we are discussing about the maternal infant health care, mental health care is one of the most important factors to work upon. While talking about women, access is something we must focus upon. Improve quality for maternity care and women living in the maternity care deserts. To get care on individuals who can marginalize for all their pregnancy needs. And anxiety and depression may occur in expectant and new moms, usually in the 7th and the 8th month. So we must have hospitals should take track of registered women and provide a free facility, and also should arrange a medical team which can provide support to women who need it and are comfortable around those medical teams. And also we must have teams which are preferable and are having access to the utilities required by the patients. And in concern of the women who are taking drugs, we must educate them that there are natural treatments that they can take, and after recovering from those, they must go for the pregnancy. And also we can take assistance of the government for arrangement of the utilities which are at higher cost, but we can provide them to the patients at the lower cost or for free. Thank you.